When you are ready, Sarah, I'm gonna just put up the screen for the agenda, and then you can take it from there. That's okay. When you are ready.
Assalamu alaikum, everyone. I hope that you're doing great. Today, I represent the Brown team as a team leader, and we will be hosting the presentations for this week's meeting. So I hope everyone is doing well. So to start with, our colleague, Dr. Sulafa, has volunteered from another team to help us and guide us through the SPSS. So Sulafa, if you're ready, please start. Thank you.
Thank you so much, Sarah. Hello, everyone.
Hi.
Hi. So I will share my screen now. Can you see my screen?
Yes.
Okay.
Yes.
Okay, so today I will continue analysis using SPSS statistics. So to start with, SPSS can do many statistics in our data. So it can do descriptive statistic, t-test, correlation, chi-square, and regression. So last week, we discussed the descriptive statistic, how we can import our files, and how we can calculate the mean, mode, median, standard deviation, and the range. T-test, as you know, if we have two groups, we can compare the mean of these two groups using the t-test. And today I will discuss the correlation and regression, and also we can calculate chi-square, or which can compare two categorical groups. So we can use SPSS to know the association between two numerical variable. Many procedures can be used to. For example, Pearson correlation. I will discuss this in a minute, and linear regression analysis. So I will start by Pearson correlation. It is used to determine the strength and direction of a link between two variables, recorded on at least one interval. So for example, weight loss and time spent in physical activity. Like, as we know, all of us, there is a correlation between weight loss and the physical activity. So if we have data variable of any gender or both gender, and we plug this data, we can calculate this. So correlation, or Pearson correlation, it tries to find the best fit line between two variable data. So for example, if we put here physical activity and we put in the Y weight loss, we can see the correlation, whether it is positive, sometimes negative correlation, and you can visually see the correlation between these numerical two variables. The Pearson correlation coefficient, which is like synonymous for it, R, show how far these data points are from the best fit line. So we can see this when I will use some data in SPSS. So you can see the relation and how far the data point from the best fit line. Okay, so before using Pearson correlation, we should test for the following four assumptions. We have assumption. If we have two numerical variables, before we run our analysis, there is four assumptions. We should test it. So continuous variable, we know our variable, we know our data. So as I showed you last time, you can see if it is categorical variable, nominal, or if it is continuous variable from SPSS or from the spreadsheet you have, like Excel or anything. You can find if it is continuous variable or if it is other type of variable. and there is also linearity. So sometimes when you put your data or your variable and you analyze it, sometimes it will not come in a linear, like straight linear. Sometimes it gave like curve. So our assumption, this relation between these two numerical variables should be linear. We can adjust for it, like to do some mathematical like log transformation or other thing, but first we should look for linearity. If no, we can manipulate for that. No outlier, I'm sorry, it is no significant outliers. So for any data, you can have outliers. Like by error, when you put your data, by error, you can have outliers. It's okay, and we can remove it, but they should not be significant outlier in our data. And also one of our assumption is normality. So it should be like normal distributed. Our observation should be normal distributed. So this is the way in SPSS. So we go to analysis, then press correlate and bivariate. The bivariate correlation dialog box pop up. And when you see it, you can transfer, and I will show you this in a minute. You will transfer your variable and make sure Pearson bottom was selected. It's usually there. It is selected by default, but make sure it is selected. There is option button. If you desire to choose a statistic, you can also choose it. And press continue button to return to bivariate correlation box, which you have seen like in the second step. And finally, you can press OK. So linear regression analysis using SPSS statistic. What I have talked to you, it's the Pearson, and now I would like to move to linear regression. Sometime we want to do our analysis on, for example, 2 or 3 variables, and sometimes one of the variable can affect the outcome. So we can predict the value of variable based on value of another variable. For example, if we take an example of also the physical exercise and weight loss, if you do more physical exercise, there will be more loss in your weight. So we can see the effect of one value on the outcome of your other variable. The dependent variable is the variable we want to forecast, which is the outcome variable. Usually it is displayed here in the y-axis. And the independent variable, another name is predictor variable, is a variable we use to predict the value of other variable. For example, lung capacity increase with increased height. So this is not fact, but if we have other variable like age, so increase in age, increase in height, and as a consequence, the lung capacity also increase. But as you know, this is like for a range only, and with also many assumptions. So this axis, the x-axis, is usually display the independent variable. So it has also assumptions, like when you do linear regression analysis, you have like 6 assumptions. The first 3 shared with the Pearson, it's the same. Like it should be continuous variable. It should be linear, no significant outliers. The other 3 is like unique for it. It's independence of observation. So for example, if we are taking some data to see the consumption of salt and the raising in blood pressure, you cannot take the blood pressure from brothers at siblings at house, or husband and wife, or father and kids, because this observation now is not independent, because they share same like tradition in food, same plate and this kind of stuff. So you can test for this assumption by using the Durbin-Waston statistic in SPSS also. Homozygosity, sorry, I'm not sure how to pronounce this terminology, which is the variance along the line of best fit remains similar as you move along the line. So, for example, if we plot the best fit, all variation around the best fit should be like parallel. We don't want it to be like triangular shape or any shape or the tail. So our assumption is our data when the variance we put around the best fit, it should be homozygosity. And we can test for this assumption too. The last assumption is normal distribution of residual or errors of the regression line. So the error in our data or observation should be normally distributed, and we can test for that by using histogram. So for linear regression, how we will do the analysis. So click analysis, analyze, then regression linear, and linear regression dialog box will pop up. You will see your variable and you can transfer the variable to the appropriate box and then check for the assumption 3, 4, 5, 6 by using statistics and plots. So when you do like scatter plot, you can visualize the linearity of your observation. So you can check for this assumption by just looking to the scatter plot and then press OK. So this is my reference. If you have any question before we move to show you the display of the analysis, please feel free to unmute yourself or put your question in the chat. Now I will move to show you what we have discussed today, like the first part. If you want to do the analysis by Pearson, so we'll go here. Can you see my screen, the SPSS screen?
Yes.
I will make it like in screen, so if any window pop up, you can all see. So you go to analyze. So last time we go to descriptive statistic. Now we'll go to correlate and we'll use the bivariate. So my example is not logic, but we can use it as I observe when I plug it, it have relationship. So this data, it is a sample in SPSS. So it is about diabetes and the cost of treating diabetes. So we have glycolated hemoglobin level and treatment cost. Of course, the treatment cost is not dependent on how high the hemoglobin level is, but we can plug this as example. So we'll choose our variable glycolated hemoglobin level and we can move it. Also, you can drag. So this time I will show you, we can drag the treatment cost instead of using the row. So here we put them together. So we will press option. If you want any statistic, you can also put it here, like in our statistic window. Okay. And then here you check if the Pearson correlation is checked, and you can see it is by default is there. And you can press OK. Then your descriptive statistic appear first because we choose it, so you can see the mean, the standard deviation, the frequency of our variable or the number. And then here you can see the correlation, all it comes, the Pearson correlation, the treatment cost, the two-tail, it is two-tail by default, the p-value, and all of this. So now you can see your data here. And if we want to see it by graph, you will go to graph. And then you can do regression variable plot. You can also, as before, choose what variable you want, you can drag it or just to move it by the arrow. And as we talk, like we can use the x-axis, the horizontal axis, like for example, glycosylated hemoglobin, and by the arrow we'll take it there, and we assume the treatment, like it is not logic, but the treatment cost is dependent on glycosylated hemoglobin, so we will move it to the vertical axis, and then we can hit okay. Also, if you go to the option, you will see if you want it like linear, cubic, or you have many options here to choose, and you just press continue and then press OK, and now should be pop up. Okay, so this is our variable, the correlation, and the graph, it is processing, and we can see it in a minute. So this graph actually not very linear. You can see it is scattered and not normally distributed around the best fit. So because as I told you, it is just rough sample to show you how we can do that. So it is not well best fit around the best fit. Okay. So this is the first part, and I can show you also the example of linear regression model. So we can go to analysis 2, and here this time, the first one for Pearson correlation, we use correlate, but here we'll use the regression and we'll choose the linear one. The same, you will choose your dependent variable. Like for example, we'll use the treatment cost, and I can use glycosylated hemoglobin as independent variable. And here, if you want, also you can go to statistic and bring your mean mode or whatever you want, or just go to the plot and plot it. If you want histogram, you can continue here, and also it will appear in a minute. So they bring the variable, you enter, and the model summary, even ANOVA, it comes here, your coefficient, and the histogram and chart should appear in a minute. Because I choose histogram, it appears for me as a histogram, but I can repeat the same step we use for a scatter plot, and it can show up here, the same page. So do you have any question about the presentation today?
I would like to thank you, Sulafa, for taking the time to learn about it and sharing your knowledge with us, and demonstrating that with examples means a lot. Like the SPSS is one of the interesting topics, and it's very challenging for us to learn. So thank you so much. I appreciate presenting it to us and helping us to further understand it. Thank you so much.
Thank you, Sarah. Sure, and thank you for giving me the opportunity, and thank you for your time.
Oh, thank you. I appreciate your help, actually. Thank you.
Thank you.
Okay, so if there's nobody, is there anybody if there's no more questions, I think we can proceed to the next section in the agenda. So we have Dr. Alaa and Dr. Avinash. They will be presenting for us neurology in geriatric population. The first part will be presented by Dr. Alaa Abdel-Gawad. So please go ahead, and Abdel Samad, sorry, I apologize for that. And let's go. Thank you.
Okay, hello everyone. Yes, today I don't know if my screen is appear to you.
Yes, we can see it.
Okay. Okay, hello everyone. Today we will talk about the geriatric neurology, and the topic that we will cover today is epilepsy. For me, I will cover the epilepsy and the movement disorder and the neuromuscular disorder, and Avinash will continue to present the peripheral neuropathy and myelopathy and headache. First of all, we'll start with the epilepsy. The seizures usually is classified to two parts. First of all, it's partial seizures or generalized seizures. The partial seizures usually it's that's the activity that starts in the one area of the brain, and sometimes it can be transmitted to the other brain parts. And we have two sections: the simple and the complex. And the simple, usually the characteristic thing is that the patient will remain alert, no loss of conscious, but sometimes it can experience some aura like nausea and abnormal taste or smell. While the complex is usually there is alter of consciousness and also behavior like confusion and repetitive movement. And as we said now, sometimes can be become generalized and spread to all over the areas of the brains. And this is it will present as a tonic-clonic. And then now we will come in 1 minute for the tonic-clonic. And regarding the generalized seizures, this is the seizure that it's spread all over the brain. And the characteristic thing here is that there is a loss of conscious, especially at the onset of the seizures. And it's divided to four main subtypes: tonic-clonic, which is called the grand mal or the convulsions with the loss of conscious. And from its name, we have a tonic and clonic. Tonic, it's mean stiffness, and clonic, it's jerky movements. And the next subtypes is the absence seizures, which is called petit nals as well, or the staring or the trance-like state, and usually happen in the children and presented as just a staring episodes. And the next subtype is the tonic or the atonic. And the tonic, which is the patients presented with the stiffness, or atonic, which is a drop attacks of abrupt fall due to loss of the tone of the muscles. And the myoclonic, usually this is sudden muscle jerks. Okay, just in general, again, we have a partial divided to simple and complex, and also generalized, which is divided to tonic-clonic, absence, tonic or atonic, or myoclonic. And usually the seizures in the geriatric populations is due to two secondary causes, like most of the cases, like 70% of the patients, due to two underlying causes. And the common causes is either cerebrovascular disease or space-occupying lesions, like any tumors in the brain, and brain trauma, and mainly the falls, which is lead to the subarachnoid hematoma or subdural hematoma, sorry, and also the neurodegenerative disease due to aging, and also it could be due to alcohol withdrawal. And to diagnose the seizures, first of all, we have to identify the causes, secondary causes, and treat the causes. And also, we have to start by, taking a good neurological history and examination in a way to try to know which type of seizures do we have, either simple or generalized. And also we have to see and localize actually its source, if it's either in the affected one part of the brain or it is generalized as well. And also the other causes is the metabolic disturbance like uremia and the hepatic failure, and that's why we have to do the CMP or comprehensive metabolic panel and check the magnesium and calcium as well. And also to know the secondary causes like the trauma or the brain, usually we do MRI or CT scans, and usually we prefer the MRI more than the CT scans. And also we do the EEG to see the electrical brain activities. And how we treat the seizures. Usually we start by giving patients like anticonvulsant drug therapy. And we have some indications that's mandatory to us to start the anticonvulsive therapy, which is if we found or if there is any presence of the focal brain abnormalities on the brain imaging, like tumor, or if it's the EEG, it's positive, or if there is, second unevoked seizures, like increase the probabilities of the further seizure from 30% to 70%. And we have here the anticonvulsive medication, which is commonly or preferred use in the geriatric populations, because as we know that the anticonvulsant drugs usually it's one of the polypharmacy medication that we usually try to avoid it in geriatric population. But the most three medications that preferred usually is lamotrigine and gabapentin and levetiracetam. And the idea here, usually we start with the low doses and we increase it slowly in the older adults according to the adaptations of patient. And also the good thing about these three medications that is not required any laboratory monitoring, and the final dose usually determined by seizures control or the adverse event, like if the patients develop any side effects of these medications and how is the seizure controls on these medications. The common causes of a breakout or breakthrough with the seizures, either the patients develop any systemic infections or metabolic disturbance, as we said now, like uremias, and also sleep deprivations as well can lead to aggravate the seizures, and also medication non-compliance. That's why we have to counsel the patients about the importance of compliance of the anticonvulsant medication. And when we have to discontinue the anticonvulsant medications, usually if the patient has not had any seizures for 2 or more years since starting the seizures, and also if the recent ECG does not show any epileptic activity. Now we will move to the movement disorder. Usually the movement disorder, it's result from dysfunction of extrapyramidal systems, and there is no any weakness or there is no any sensory, it's just only a pure motor due to dysfunction of extrapyramidal system. And we can classify the movement disorder to the hypokinesia or hyperkinesia. And what we mean by the hypokinesia, which is the paucity of movement, and it's the good example is the Parkinson disease and or idiopathic Parkinson disease. And also we have a Parkinson plus syndrome, where we experience Parkinson in addition to the other features. And actually, unfortunately, this kind of Parkinson plus syndrome is usually less responsive to dopaminergic medications comparing to the Parkinson disease. And we have the hyperkinesia, which is characterized by the excessive movement. And example of this is chorea, where we found it in Huntington disease. We have dyskinesia and dystonia, which is sometimes this could be a side effect of antipsychotic medication, psychotic medication, sorry, and tremors as well, like essential tremors. First of all, we will talk about the Parkinson disease, and this is actually due to, it's resulting from a neuronal dysfunction, a neuronal loss in pathway, in either in the brainstem or the basal ganglia, especially the substantia nigra or cerebral cortex, which can lead to progressive neurodegenerative disease. And the pathologies we found is Lewy body accumulations and in dopaminergic neurons, especially in substantia nigra, and the Lewy body is an intracellular inclusion body. And these changes, it lead to the symptom and signs, which is we know about the Parkinson disease, which are the tremor at rest, bradykinesia, rigidity, and postural instability. And also, sometimes if this Lewy body is accumulated in the cerebral cortex, mainly in the limbic region or the neurocortex can lead to the neuropsychiatric or cognitive symptom. Usually the diagnosis of the Parkinson disease, we have a criteria. First of all, we have required evidence of bradykinesia with either resting tremor or muscle rigidity or both. That means the bradykinesia is very important requirement to diagnose Parkinson disease. And also we have a fourth cardinal motor feature like impaired postural reflexes. And the characteristic about this impairment of the postural reflexes usually in the idiopathic Parkinson disease usually appear in the later presentation in the course of idiopathic BD. But if it's appear in the early course, this is indicate of Parkinson plus syndrome. Here now the treatment of the Parkinson disease is divided to non-pharmacological and pharmacological treatments. In the non-pharmacological treatments, we can advise or counsel the patients regarding the regular exercise program and also PT or OT. And PT, which is the physical therapy, and this is actually to increase the confidence of the patients in the walking and how it's maintained their balance, and also to teach the patients how to manage of the freezing episodes when he experiences, and also how to use the can or the walker if needed. And also we can arrange a home visit for the occupational therapist to plan placement of the assistive devices. And the pharmacological treatment, which is the best one or the effective medical treatment, is the carbidopa-levodopa. And actually, usually we're starting by giving the patient half tablet of carbidopa-levodopa, which is the concentrations is 25 of carbidopa and 100 to the levodopa. And usually we give it every 8 to 12 hours. And actually, we will start by increasing these dose half tablets every 1 to 2 weeks until we reach the requirement, which is a 1 full tablet 3 times a day. And usually, the action is typically working for 4 hours. And if the symptom is still persistent after this medication, we can gradually increase this doses. But the maximum we can reach is the 1,000 for the levodopa. We cannot exceed the more than 1,000 of levodopa in geriatric populations. And the common side effects of these, it's nausea, abdominal cramps, and orthostatic hypotension, and also visual hallucination. Okay, how we manage usually the BD symptoms. The symptoms are commonly prescribed as follow. We called on or on with dyskinesia or off. When that means this patient is well controlled with the medication, no any symptoms appear, no dyskinesia, no bradykinesia or anything. In the on with the dyskinesia, usually that means when we found on, that means the patient is controlled, but have some complications, which is a dyskinesia. If the patient describes it as off, then that means this patient is not controlled either due to a non-compliance or due to abnormal doses of this or levodopa or carbidopa. And how we treat this too, which is on with dyskinesia or off. When the patient has a off symptom, then first of all, we start by increasing the dose of the levodopa to every 3 to 4 hours, or we can add some medication, which is the enzyme inhibitor, like rasigulins or entacapone, to increase the durations of action of the levodopa. If the patients also, have on dyskinesia, we can also increase the interval between the levodopa dose or lower the total daily dose of dopaminergic medications. And sometimes, if you want to decrease the severity of dyskinesia, we can introduce a dopamine agonist in the early management as a monotherapy. This is here just revisions about what we learned in the steps First of all, here we have the blood-brain barrier, and we have here the blood, and we have the L-DOPA. The only form of dopamine that can cross the blood-brain barriers is the L-DOPA. And in the blood, usually the L-DOPA is divided to 3 OMDs by the COMT. And we have 2 medications that can inhibit the COMT enzymes, which is catyl O methyltransferase, which is entacapone and tolcapone. And also the L-DOPA can be degraded by the DOPA decarboxylase to dopamine, and the medication that inhibit the DOPA decarboxylase is carbidopa. And if we have the high dopamine, it can lead to the side effects, which is nausea, vomiting, arrhythmias, and posture hypertension. This is what we discussed now. This is the side effects of dopamine medications. And when the L-DOPA cross the blood-brain barrier, and now again the L-DOPA, it will return again to the dopamine, or divided to the dopamine, and then the dopamine, it will divide by the COMT to the 3-methyltransferase, and the only medications is work in brain is tolcapone, no more entacapone in the brain. And also the dopamine, it will divided to DOPAG by MAO-B, and the 2 medications that work in the MAO-B is selegiline and the risogilline. And when the dopamine now reach the final destination, which is the dopamine receptors, and we have some medications which is work as dopamine actually agonists, which is bromocriptine, pramipexole, or robenilol. And also we have some medication that it will target it, the dopamine receptor. And here, this is the other medication that we can use it for the BD, which is the COMT inhibitor, MAO-B inhibitors, amantadines, and also anticholinergic medications, and dopamine agonists like ropivirone, pramipexole, or rotigotine transdermal patches. Okay, we have also other treatment options for the BD, which is the deep brain stimulation. This is actually it will increase the on times and decrease the dyskinesia. And usually there is no any cutoff age of this treatment option, but we cannot use it in the patients less than more than 18. It's usually performed in less than 18 years. And the complication of these intervention, it's surgical site infections. It can lead to the hemorrhage and death in up to the 1% of the patients. In addition, it can also lead to the cognitive and speech problem and increase the risk of fall. We have non-motor symptoms, which usually the BD patient can be experiencing, which is urinary incontinence, some constipation, drooling, supraia, and anxiety, depression, and visual hallucination, sleep disorder, and cognitive dysfunction, which is the neurocognitive symptoms. And also we have something very important, which is the patients with the BD have a high risk of melanoma. That means we have to also counsel the patients about the screening, about the melanoma, and also the importance of using the sunscreen. Regarding the visual hallucination and delusion, we can treat it by give the patients or adjust actually the dopaminergic regimen, or maybe decrease the doses. And we have a new medication which is called bamavistyrine, which this is a new medication. It helps to treat the psychosis, and it's usually the good thing about it is also it's not required any laboratory monitoring. And also, if the patient have dementia symptom, we can use cholinesterase inhibitor like rivastigmine. We have something called like multiple system atrophy. Usually is combined, or it is Parkinson's plus syndromes. And we have 3 clinical syndrome is usually associated with the Parkinson, which is olivopontocerebral atrophy, or Shy-Drager syndrome, or striatonegral degeneration. This is the 3 main syndrome associated with the Parkinson's. And usually we found the Parkinson's or Parkinsonism plus autonomic failure, like postural hypotensions. And usually if the patient have these postural hypotension, we give midodrines or corticosteroid or droxidopa, and also in addition to cerebellar dysfunction. The other movement disorder, which is chorea, and the definition of the chorea is usually like flowing, continuous random movement that usually migrate from the one part of the body to another, and the main problems or the dysfunctions in the striatum, and the causes. The main causes is Huntington disease, where we have striatum dysfunctions, and also drug. Some drug also can lead to chorea, and the stroke, especially if the stroke is affected the striatum, is also can present with chorea, and the age or senile chorea, where when the degeneration can happen also to striatum. And in this part, we will treat it usually with the dopamine receptor blocker, like risperidone or haloperidol. And we have also, but actually these medication have a side effect, which is Devis dyskinesia. And we can use tetrabenazines or deutetrabenazines, which is also helpful to treating the chorea, but there is no risk of that Devis dyskinesia. The dystonia, which is here, it's a hyperkinetic movement disorder, and it's lead to sustained muscle contractions using twisting movement or abnormal postures. And we have 4 common dystonias seen usually in geriatric population. First of all, we have a cervical dystonia, which is where the neck muscle sometimes gets spastic. It's called spasmodic torticollis. And we have pleural spasm, which is contractions of the eye muscles. We have a spasmodic dysphonia, which is usually and it can lead to the dysphagia and also hoarseness, and also a focal hand dystonia, which is contractions of the hand muscle when you start writing, which is called the writer cramps. And the treatments of this kind of dystonia, we give anticholinergic or muscle relaxant like piclofan. And sometimes we can use some temporarily or local or focal treatment like botulinum toxin injections. The last actually movement disorder that we will talk about today is the restless leg syndrome, and this is usually uncomfortable feeling or urge to move your legs at night especially, and usually it's improved with the movement. And it's not only affected the legs, sometimes it can affect also the arms, and it's also associated with positive family history of the same conditions. And we can use polysonography to diagnose it, but it's not required for the diagnosis. And what we can see in the polysomnographies, we can see periodic limb movement asleep, and this is like involuntary limb movement while asleep. And usually this is only in 80 to 90% of the patients with the RLS, but BMS is not specific for the RLS. And the treatment usually for restless leg syndrome, we will not usually treat it unless it is severe or it could be affected the quality of life. And dopaminergic agonist, this is the best choice of treatments. We give pramipexole or Robinol or rutigotines, and we give it also 1 to 2 hours before the bedtime. And if you want to use medication just as needed, we can use a carbidopa levodopa, usually also at nighttime doses. We can also give gabapentin, pregabalines, and there is some researches suggested that the RLS could be associated with the iron deficiency anemia, and that when we give the patients iron supplementation or replacement can improve the RLS. Just to recap what we're talking about, the seizures, actually the new onset seizures in late life are frequency and symptom of underlying brain disease injury. That's why we have to investigate more. And the recurrent seizures can be prevented by giving the patient medications. And the best treatment for the seizure is lamotrigine, gabapentin, and levetiracetam. The Parkinson disease, it's other common movement disorder in the geriatric populations. We can diagnose it clinically, but we manage it medically. We have a case here. Now we have to solve it together. I will start reading the cases. A 70-year-old man is admitted to the long-term care facility. Previously, he lived alone with the home health service and family support. He was independent, eating, ambulating, managing his own medications. He's required help for almost ADLS. In the past 3 months, he has had increased fatigue, worsening ambulations, urinary and fecal incontinence, and decreasing cognitive functions. He is now in a wheelchair and wears incontinence pads. Since his recent cognitive and functional decline began, he has had 2 episodes of lethargy, slurred speech, and confusion that lasted for an hour or 2 and then resolved. Okay, and then the history. Mild dementias, MI 1 year ago, and began benign prostatic hyperplasia and osteoporosis. The medications, dubonazole, aspirin, metoprolol, rovastatin, losartan, furosemide, tamsulosin, calcium, vitamin D. And on examination, the patient is alert and fully oriented, but he does not recognize a family and cannot find a symbol command. Normal vital signs, no convulsions, normal muscle tone, have a 1+ pitting edema to the mid-chin bilateral. Echo 1 year ago, ejection fractures at 38%. The questions are like, which of the following is the best next step in evaluating this patient functional decline? The standardized cognitive assessment, depression screen, EEG, lumbar puncture. Anyone can solve that? I don't know, I cannot see the chat.
So Heba said B and Tamadr said C.
Okay, actually we can go back here and we can read this arrow again. Like, since his recent cognitive and functional decline began, he has had 2 episodes of lethargy, slurred speech, and confusion that lasted for an hour or 2 and then resolve. That means it could be seizures going on, and that's why we have to do EEG to exclude the seizures. And then otherwise we can, if it's negative, then we can say it's more dementia. Okay, that's it. And thank you. Anyone have any questions? Or any addition or?
Thank you, Dr. Alaa. The summary is very elaborative and very extensive. Thank you so much for explaining to us part of the geriatric neurology. Actually, there's Dr. Muhammad Ibrahim. He had a couple of comments and a question. So he mentioned that infections also present common causes of seizure. The other comment is that lamotrigine is famous of its hypersensitivity reactions. And he has a question, when do a patient with epilepsy is allowed to drive a car? So do you have any comments or responses to that? Thank you.
Thank you so much, Dr. Alaa and Dr. Sulafa, for the presentation. This is great, and hopefully this will help everyone. So I'm gonna jump in for the question about driving after seizure. So usually when they diagnose the seizure first time, they want you to be treated and free from any new seizures for about 6 months or so. But in the US, it depends on the state. So each state they have their own laws or regulations. So there is a website where you can go to, it's epilepsy.com, and then you can go to the driving and transportation section where you can ask about which state the patient is in, and you can compare more than one state to see the laws, the different laws. I'm not sure about other countries like UK, Ireland. And,
yes, actually in Virginia here, I live in Virginia, and usually they don't allow for the patients to drive for the next 6 months. Yes, and then after the 6 months, then we do another like assessments and see how the patients any provocations of seizures, and then yes, decide. But yeah, as you said, like according to each state.
Yes. Thank you so much.
Thank you, Dr. Nader, and thank you, Dr. Alaa, for your presentation one more time. I think if there's any no more questions, I think we can start with Dr. Avinash to present the second part of the neurology in geriatric population.
Yes, let me share my screen. Do you guys see my screen?
Yes.
Okay. So the peripheral neuropathy can be defined as the damage or dysfunction of the nerve, which can be presented with the complaint of weakness, numbness, or tingling. It can be particularly devastating in the older adults because it may cause the gait impairment from the sensory and the motor deficits, which can cause the fall. The prevalence up to 10% in the older adults and 30 to 60% in the patients who are more than 60 years who have a diabetes mellitus. So the diabetes mellitus is one of the most common cause of the peripheral neuropathy, while we can discuss about the other common cause in which include the medications such as isoniazid and anti-cancer drugs like vincristine, vinblastine, and alcohol abuse, and the nutritional deficiencies like folate deficiency, vitamin B12 deficiency, and the renal disease, multiple myeloma, and other neoplasia. The diagnosis of peripheral neuropathy, for that the history is most important. In the history, we had to ask about how the neuropathy started, like how the tingling and numbness started. Is it getting worse, or what was the pattern of that neuropathy? Is it involve first the thigh up to the foot, or it start from the foot, then it ascending pattern up to involve the thigh? Okay, then we have to do the neurological examination to confirm it. Either it involved only the nervous system or it involved the muscles and reflexes also. And we can diagnose it with the help of electromyography and nerve conduction studies, which can classify the neuropathy. The treatment of the peripheral neuropathy is depend on the underlying cause. If it is like diabetes, we can have to treat the diabetes to make sure their hemoglobin A1C level remain in the range to not worsen that conditions. And we get, okay. So we have a couple of like the options for the treatment of the neuropathy. That is the gabapentin, pregabalin, and the duloxetine. These are the drugs which we are using for the neuropathy. Okay. Now we comes to the radiculopathy. Radiculopathy is the compression of the spinal root as it exits from the spinal cord. When anything which compresses the spinal root, it causes the radiculopathy. Radiculopathy can present also the same as like the neuropathy. It can cause a weakness, numbness, and tingling. So in the older adult, it may result from the herniated disc or any abnormal bone formation. If it involves the cervical vertebra, it can cause the neck pain, and the pain is radiated to the arms. But if it involves the lumbar vertebra, it can cause the back pain, and it radiated to the legs. The neurological examination may reveal the motor and sensory deficits along with the hyporeflexia. And for the diagnosis, we had to do the MRI with contrast and lumbar puncture with cytology, which may help to make the diagnosis. There are two types of radiculopathy. The one most common cause is the acute inflammatory demyelinating polyradicular neuropathy, which is also termed as Guillain-Barré syndrome, which is an acute immune-mediated form of polyradiculopathy. It is started mostly after the respiratory tract infection or the diarrhea, which is caused by the Campylobacter jejuni, in which the antibody kills the bacteria as well as they are attacking on our normal nerves. It can treat it with the plasma exchange, that we call as plasmapheresis, or we can treat it with the intravenous immunoglobulin. Okay. And now it comes to the later part, that is myopathy. It is a disease of the muscles, which is characterized by the proximal muscle weakness, wasting, and hyporeflexia. We can diagnose it with the help of the muscle enzymes, which are increases like creatine kinase and aldolase. And we have to diagnose with the help of electromyogram, which will show the myopathic pattern, and abnormal muscle biopsy. Polymyositis is the most common type of the myopathy, which is a disorder of the skeletal muscle, in which the muscle biopsy shows the signs of the lymphocytic infiltration, in which the patient is unable to open the door or unable to do the comb. And the prednisolone is the treatment of choice, but it should be used with caution in the older adults, because the prednisone, again, it has a lot of side effects. It causes the osteoporosis or the vertebral fracture. Myopathy can be caused by the thyroid. So we had to check the thyroid profile, TSH, T3, T4. If it is hypothyroid, we had to treat them with the replacement of the thyroxine tablets. And it can also be caused by the drug induced, for example, with corticosteroid, lipid lowering agents such as rosuvastatin, colchicine, and procainamide. Another is the motor neuron disease. We call it amyotrophic lateral sclerosis. It is a progressive fatal neurodegenerative disease which involves the both upper as well as the lower motor neuron cell bodies. So we will get the features of the both upper and lower motor neuron findings. It is a progressive weakness and wasting of the skeletal muscle, often in combination with the bulbar palsy and the respiratory failure. Common symptoms we find in this disease are the gait disturbances, recurrence of the fall, foot drops, weakness in the grips, difficulty in swallowing, and difficulty in articulation. On the neurological examination, patients may have the combination of the upper motor neuron signs. These are the hyperreflexia and Babinski signs positive. And the lower motor neuron signs are the weakness, atrophy, fasciculation, and flaccid paralysis. And as always, it is associated with bulbar palsy and respiratory failure, so it involves the weakness of the face, tongue, and palate. These are common. And electromyography demonstrates the findings which are consistent with diffuse denervation and poor recruitment of the motor units. Okay, another is a myelopathy, which is a spinal cord dysfunction. There are a lot of causes of the myelopathy, either it is intrinsic or extrinsic. In the intrinsic cause, can be result from the spinal cord tumor or the infarction or the hemorrhage, which involve the spinal cord supplying, or it is extrinsic cause like the cervical spondylosis, disc prolapse or herniation, or the vertebral body subluxation. MRI is the most helpful for the diagnosis, and the treatment myelopathy can be treated by the decompressive surgery. Now we come to the topic of the headache, which is the very most common, and the prevalence appears to be decreases with age. The new onset or persistent headache in older adults are more likely to have a secondary cause, such as any intracranial mass or tumor, any spondylosis, COPD, obstructive sleep apnea can present with headache and fatigue, carbon monoxide poisoning, and the giant cell arteritis, which is a vasculitis. So in the older adults, always do the brain imaging with the contrast, with if the patients develop headache with new onset or progressive headaches. So giant cell arteritis, it is one of the type of the vasculitis. It is most commonly happens in the patients who are more than 50 years old, peak in incidence between the age 70 and 80. Women are affected twice, and the pain can be located at the temporal or the occipital arteries. And on the physical examination, when we do the palpation, it causes the focal tenderness of the scalp arteries, mostly on the temporal region. And it can present with the visual changes, low-grade fever, polymyalgia, and constitutional symptoms others. These things further suggest the diagnosis. And mostly the ESR is always raised in the temporal arteritis. Migraine. Headache of the moderate to severe intensity associated with nausea, vomiting, photophobia. Migraine, there are two types, migraine without aura or migraine with aura. Aura, these are the kind of the signs which are happens before the headache, like the flashing of the light or tinnitus, like ringing sound in the ears. So it is mostly involved the unilateral and a temporal involved, and it is characterized by the thrombic pain, but commonly the pain is bilateral. Treatment of migraine. Migraine can be treated by two types of therapy. One is abortive and another is a prophylactic. Abortive therapy, which is mostly used in acute management. We are using the over-the-counter NSAIDs like indomethacin or ibuprofen. And other options we have are the ergotamines or the sumatriptans. But make sure these are contraindicated in the patients with uncontrolled hypertension, stroke. And the preventive therapies we are used for the prophylactic when patients have more than 2 migraines per month. And the most common drugs which are used for the prophylactic is the propranolol, beta blocker. Other headache types are the cluster headache, which is more common in the men, which is associated with tearing and rhinorrhea. It is a very short duration than the migraines, 15 minutes, most commonly last up to the 3 hours. And other headaches are the chronic daily headaches, which is persistent and often bilateral. And the features are overlapping to those of the migraine and tension type. Now let's discuss the couple of cases. At a 3-year-old woman comes for the follow-up for the pain and tingling in both feet and lower legs. Her husband says that the symptoms interfere with her sleep. Gabapentin and topical capsaicin were started at her last appointment 3 months ago. The pain has been getting worse despite treatment. Hemoglobin A1C at that time was 8.1. She has fallen once since the appointment while walking to the bathroom at night. Past medical history, osteoporosis, hypertension, moderate dementia, and diabetes mellitus. And she's taking medications, calcium, vitamin D, alendronate, losartan, metformin, insulin, gabapentin, and topical capsaicin. Examination, blood pressure is 144/88, and she is mildly obese and no distress. Her vision is corrected and intact. There is no any musculoskeletal finding, but on the monofilament exam, we have found the impaired sensation to light touch in the feet and lower legs bilaterally. Positive Rombert sign, gait is slow, white-based, and unsteady with the cane, and she touches the wall to stabilize herself during ambulation. So which one of the following is the best choice to replace the gabapentin to treat this patient's neuropathic pain? Amitriptyline, pregabalin, citalopram, or duloxetine? Anyone guess? Okay, so this is the neuropathic pain as she already taken the gabapentin, but it is not giving her relief. And so the correct answer is duloxetine. Because amitriptyline, again, they have a lot of side effect of anticholinergic properties, and pregabalin similar to the gabapentin, and it is not working. And so we have to give them the duloxetine. Okay, next case is an 80-year-old man has had daily headaches for the past few weeks. He is accompanied by his son who answers most of the questions. He lives with his wife and son, and it is dependent for cooking, cleaning, bathing, and dressing. He has had no real disturbances, fever, or weakness. History having the moderate dementia. His son stated that his father memory is getting worse. On examination, we found that he has lost 6.8 kg since his last appointment 9 months ago. He has a poor eye contact and it is easily distracted. Hygiene is poor. There is a tenderness over the lower jaw bilaterally and bruising over the scalp, jaw, and wrist. There is a grade 2 pressure injury over the presacral area, and the scores on the MCA is 24. Laboratory finding albumin is 1.8, ESR is 20, CT head show no bleeding, no fracture. Which one of the following should be the next step in the management? Prescribe sumatriptan, call Elder Protective Services, start prednisone and order temporal artery biopsy, order lumbar puncture. That's correct. Call Elder Protective Services. Thank you so much. Any questions?
Dr. Avinash?
Hello.
Hi, Doctor.
Hi.
I've just noticed that you've mentioned lumbar puncture in the diagnosis of radiculopathy. I just wonder why is that. Thank you. Nice presentation. Thanks.
Thank you. So the radiculopathy, yes, we found that sometimes we had to do the lumbar punctures to see for the cytology pictures. Either it is because of sometimes the tumor can cause the compression of that nerve root. So we can get the some cells or any abnormal proteins in that. That's why they have performed the lumbar puncture.
Thank you.
Mm-hmm. Anyone have other questions?
Thank you, Dr. Avinash, for a great presentation. Actually, we've been learning a lot. I actually appreciate this review in neurology, not only geriatrics, but also like a general practice. Thank you, Dr. Avinash, and thank you, Dr. Alaa. I appreciate that so much. So I think if there's no other questions, we will move on to the next part on our agenda. So it will be other opportunities, like return in terms of like graduate education. It will be presented by me, and actually, just allow me to share my screen quickly. So actually, it will be like a quick, like open discussion. So just like it's for declaration, like this is like what we're talking about here. So it will be an open discussion where we all like have pursued different pathways as an alternative, decide like medicine and after medicine, after finishing our USMLE exams. I'll be talking about what I pursued. I pursued a master's in public health at Ohio University. It's an online program, so like I can have the luxury to take it like at anywhere all over the world. There are just like few tricks because sometimes people feel intimidated by the admission process and how we can take care of things. So first of all, like the paperwork is we submit our certificate and graduation certificate and the medical school transcripts with credit hour, and we do that, equate that to GPA, and we use the service called, the most famous one is WES, which is the World Educational Service, where it like it changes the GPA in a good score and also like transfers everything into correct number of credit hours. It's a process that takes around like 1 month to do that. And the only trick about it is that the paperwork, and we have to like transfer the certificates from the university itself, and it should be like it has the university seal before we send it to the organization. Some programs require GRE test. My program didn't require it, and however, the GRE generally waived for us international medical graduates who are also ECFMG certified. So like we don't have to do any further studies about that. Also, they want to check for our fluency in languages, such as like the TOEFL or the IELTS, and also they can be waived if we had our medical education in English, and that's the case in Egypt, and I expect that like also like in India, in Sudan, and other countries, that we just like ask one of the employee in the or graduate affairs employee in the university and the medical school just to write a letter that we had our medical education English and we are fluent in that and we are aware of the like medical terminology in English and we don't need like any other studies in TOEFL or IELTS, and it's most of the time like it goes on like just like the process proceeds without the need to go further studies in the English exams. Also, another concern is the cost, because it's very expensive. Like we pay per course, and we are used to like to have the public medical education in our countries, which is like more affordable than the case here in the United States. So there are like multiple options. Like if you are a US citizen, so usually we apply for federal loans, and we can be paid after we finish the MPH or the graduate degree we have applied for. If the non-US citizen, there is like some sort of personal loans or educational loans. The best one I've like during my search is Discover, where there's like particular loans for medical professionals, and there's like a forgiving window of 6 months after graduation. And or you can just simply pay it out of pocket. These are the options, and you choose based on your values, religious values, cultural values, based on your occupation, based on your financial stabilities. It varies. Again, it's just a personal choice. So the second thing is like the next thing is what are the career potentials after the MPH? First of all, now particularly after the COVID, there is a calling for something called population health or population medicine, where particularly in primary care practice, where they want to incorporate the concepts of public health into medical care, so that they want to be like they want the care to be more inclusive, and we want to like not only provide medical care to the patients in the clinic, but we just want to make sure that we address the other barriers of care, is a social, economic, environmental, and mental barriers, behavioral barriers, and how to incorporate that in the patient-centered care model. If anybody's interested to like have like alternative professional pathway, but yet within the medical field, there are like healthcare administration, an epidemiologist, social and community service manager. These are the career potentials. Like this is a few, but there are other pathways. So this is about it, the MPH, and this is like a sort of my personal experience. But I believe there are like other colleagues of us like who pursued different graduate education, further professional studies in global health or masters of science in healthcare. And that's it about it. And if anybody would like to share their experiences as well, or have like tips to better facilitate the process of enrolling into a program, please go ahead. Thank you.
Thank you so much, Dr. Sarah and Dr. Avinash. This is great. Thank you. Any questions to any of the presenters or for the discussion? Any addition, any personal experience that any one of you wants to share?
Yes, thank you, Dr. Sarah, for your presentation, and Dr. Sulafa and Avinash for all the hard work you done, guys. Yes, my personal experience, actually, I see that the pathway that Dr. Sarah say they having a master degree in public health or global or health science, that's a great idea if in case they matched, they went well. But I do see that inshallah will be matched this year and we don't need. But in general, for my own experience, everyone is asking me about my master health degree, and everyone asking me about my telegeriatric research certificate and what it's benefit me as a physician. So I think this is beside the match and the application, even it's enhanced me as a physician in my analytical skills and see things from different perspective, and more passionate about understanding why this happening. This is now what I'm experiencing is everything is, why is this happening? I'm starting to questioning things. So yeah, that's my own experience and I wanted to share.
Thank you, Dr. Helen, for your input. It's very valuable. Thank you so much. Please go ahead, Somi.
Yeah, thank you, Dr. Avinash and Dr. Amma, for the great presentation. As usual, like I want to add, already Sarah and Hiba actually explained very well, but what I want to add is, I think having a master's degree, like either way, it will never hurt our CV. It's also for our, it is a great asset for our residency application. And it is also a good things for plan B. In case it does not work, then I mean to say, like residency does not work, then we have a lot of options open, especially because of this COVID and post COVID situation. There are multiple jobs opening, like epidemiologist or like clinical documentation specialist, something like that. So, and I want to add about a little bit about the programs, like as Sarah mentioned, like many of you here probably like green card holder or citizen. For those people, like I think it's very easy, like if you are even working in a university environment, and even you are working kind of a research position or something, there are many programs, they reimburse your tuition. That is one option. Another option could be like you can apply for a lot of scholarships, which I'm still enrolled in Masters of Global Health in Michigan State University. So they have multiple scholarship program where if you can easily get it and through the program, and that can be they can reimburse your tuition and whatnot. So there are multiple opportunities for tuition. And another new things for COVID things is most of the programs, they are pretty flexible now. And I can see like even global health program in Michigan State and public health program in Michigan State, both of the programs now, they do not need any GRE requirements because of the pandemic. And other options is like programs are flexible, and also they have like online option. Most of the program now goes to online because of the pandemic. So, like you can even conduct independent research or something like that where you are located. And at the same time, you can have a master's degree from a good university, and it will never hurt you. That's all I can say. I was very hesitant, after doing USMLE, like what should I do while waiting for residency, but I think this is the best way. Thank you. If you have anybody have any specific questions that I can answer, you can ask me. Thank you.
Thank you so much, Sumi. It's very helpful, particularly the scholarship part and the reimbursement part. It makes a whole difference, definitely. Thanks again. So is there anybody who has any questions or would like to share their own experience as well? Please, you're welcome to share.
Yes, hello everyone.
Hi.
Yeah, I'm also going to share that I have got a license of assistant physician in Missouri State. So, and I will present about this kind of alternatives or even a transition from now until when accepted to residency in the green team presentation.
That would be great.
Yeah, the other thing that I get an opportunity to join a global health certificate program with Wayne State University. Unfortunately, it's free. I have to pay nothing. Just I only work with one of the cardiologists who is affiliated to the Detroit Medical Center, and just asked me to submit my CV and a letter of recommendation from my employer. and now I have like 6 months doing the global health, and it's kind of easy. Just a seminar every month with one assignment that should be done before the seminar, and with one capstone for a group of students every year. And that's it. Thank you.
Thank you so much, Dr. Mohammed. This is really great. Thanks for sharing. And thank you, Dr. Alaa and Sumi, and thanks for sharing all this great information, great presentations. Anyone else wants to share? So I'm gonna share with you this website. So basically, you can do the master program as mentioned by Sarah or Hiba or other people who are involved in the master, but sometimes it may be difficult for someone who just graduate to think about a master because it's require a lot of money, a lot of time, and commitment. The alternative is to see a certificate program, and even you can start with baby steps. You can just focus on perhaps start with one course. You don't have to think about the certificate or the master. Just put your name as a student in one of the institutions out there who provide online classes. For example, I can just share with you here at MSU, they have other online classes and certificate programs. Here I put some of the examples. For me, as an attending at the Department of Family Medicine, I found a leadership program also. What I did last year is to start just with one class or course. I finished that, and now I'm joining them to enroll in a second one. And there is a third one. If I finish 3 of them, I will get a certificate in this leadership or program. So anything can help you in your CV, and it can help you do whatever you want to do in the future. I think might be of benefit to you, and it will be considered also in your application down the road, or when you are promoting yourself, if you join academic institutions, for instance. Thank you.
Thank you, Dr. Nader, for sharing that with us. Actually, like it's a good idea to have like many multiple certificates to apply to certificate degree as a step to make it an easier step to apply for like a master's in public health. Thank you so much.
Thank you. And if you take one class, I think you can focus. And if you score high, let's say 4 out of 4, then this will also help you if you apply for a scholarship or assistantship or whatever. They will look at, oh, you are a really good student, so we'll pay for your tuition and so forth. So thank you.
Thanks, Dr. Nader.
Yeah, exactly. Like that's, I forgot to mention that, as Dr. Nadir mentioned. Yeah, it is for applying for a scholarship, like there are some GPA, a specific GPA requirement, but after the first course, as now there are no GRE, like required. So only they can evaluate you for, like, let's say graduate certificate course for global health, it requires like 9 credit hours. So that means like you need to finish 3 semesters. So one semester you can earn like 3 credit hours. So that means 3 semester means 9 credit hours. So one first semester, if your GPA is 4, then you are eligible to apply for any kind of a scholarship. And I mean, they said like 3.8 and above, but at least you need 4. I mean, the more the best. And also, if you are working in a university, that is also a requirement. If they want to reimburse your tuition, they always look at your GPA, because that's how they're, you know, everything is very competitive. So if they have like, let's say like from your department, like 5 people apply for reimbursement, so whoever got the best GPA, they approve for those people. And that's how it worked for me. So I wanted to share that. Thank you.
Thank you so much, Soon. I appreciate that. Okay, so if nobody has like any input to share or any questions, we can move ahead with the agenda. So Dr. Avinash will be sharing with us the COVID updates. Please, Dr. Avinash, go ahead. So Dr. Avinash, we cannot hear you. So it's okay, you can unmute yourself.
Let me share my screen. Okay, do you guys see my screen?
No. Yes, we can see it now.
Okay. Okay, so this is a short presentation, Omicron variant. The first case of Omicron, which was detected on the November 11 and November 14 in the South Africa, and it was first reported to the WHO on the November 24, and on the November 26, WHO designated it as a variant of concern. We will discuss later what is variant of concern. And on the December 1, the first case in the US were identified. So this is the shape or the structure of the virus. This is the membrane, and this is the spikes. These are the spikes, which are the proteinaceous used by the virus to attach the human cells. If anything changes in these spikes, it may result in the change in the virus transmissibility, or the virus may escape the immunity. So the more the virus circulate, the more the virus will evolve. And some of the changes to the SARS-CoV-2 lead to the emergence of the variant that may affect the virus transmissibility and their severity and the presentation. Let's discuss about now what is the variant of interest and what is the variant of concern. Okay, so Omicron variant is most likely to be transmissible than the original SARS-CoV-2. Even the vaccinated people got the infection, and even the people who are previously infected, they become infected again from the Omicron variant. So the vaccines is very important, expected to protect against the severe illness, hospitalization, and death. So these are the terms variant of interest and variant of concern. Now, variant with genetic changes that are predicted or known to affect the virus characteristics, such as the transmissibility, disease severity, and immune escape or diagnostic or therapeutic escape, and that causes or community transmission or multiple COVID-19 cases. And the variant of concern is same is meet the definition of variant of interest, but has been associated with one or more of the following changes at a degree of global public health significance. These increase in the transmissibility, like as we said that Omicron has a property of transmissibility. It is very highly transmissible virus, and increase in the virulence or change in the clinical disease presentation, and the decrease in the effectiveness of the public health and social measures or available diagnostic vaccines and therapeutics, because the companies are going to research on that. They are going to present one new vaccine for the Omicron separate. Okay, so let's have a look on the spike protein of the Delta and Omicron. This is one spike protein, and this is the S1 domain of the spike protein. As in the Delta, we got the 40 to 70% of the mutation, but in the Omicron, it is more than 70% of the mutation. That's why the vaccine is not going to help from this Omicron. On November 26, WHO designated it as a variant of concern because of the preliminary evidence of the detrimental changes in the epidemiology. Omicron has a larger number of mutations, at least more than 30 genetic mutations of the spike protein. And some mutations have previously been associated with increasing transmissibility and making it easier for the virus to bind and attach the cells and escape the immunity. The current knowledge about the Omicron is that it is highly transmissible. It can cause the reinfection, and we can detect it with the help of PCR and antigen detection. And the clinical management of Omicron is a corticosteroid and interleukin-6 receptor blockers do not target the spike protein, but is still effective for managing the patients with severe COVID-19. So the three key properties of the variant which are likely to influence the overall threat from it. One is its transmissibility relative to the circulating variant, and another is its virulence, ability to cause the severe disease, and its third one is its ability to evade the immune response. So this is a global approach to monitor and assess the SARS-CoV-2 variant, including Omicron, which is one of the monitoring and surveillance. And second one is the evidence and assessment. And third one is that we have to make the policy, like the government and hospitals, they have to make the policy against these viruses. These are some preventive measures which are effectively reduce the risk of COVID-19, including the Delta and Omicron. Keep a physical distance of at least 1 meter from others. Wear a well-fitting mask. Open windows to improve the ventilation. Avoid poorly ventilated or crowded space. Wash hand frequently. Cough or sneeze into a bent elbow or tissue, and get vaccinated as soon as possible when it is your time. So the robust response to the Delta helped response to the Omicron and other SARS-CoV-2 variant. It is advised for all countries to always continue to implement the effective public health and social measures to reduce the COVID-19 circulation, in which it includes the increased vaccination coverage and at-risk population in all countries, and identify those populations who are not yet vaccinated and target the most vulnerable populations like children, old age population, and the population with comorbid conditions like diabetes, hypertension, cancers, and enhance the surveillance and submit the complete genome sequence, report as soon as possible the initial case or clusters, which is associated with variant of concerns. So these are a couple of strategies, the prevention strategies to slow the United States spreads of the Omicron variant. One is the vaccination. It is recommended for everyone who are aged more than 5 years. And the booster is recommended for all persons who are aged more than 16 years and who took the Janssen vaccine before 2 months, and the Pfizer, BioNTech, and Moderna before 6 months. And increased use of masking, improved ventilation, wider and more frequent testing include self-testing and adherence to the guidance on the quarantine and isolation. So the booster and second generation vaccines are against SARS-CoV-2 variants. As I said, the Pfizer's, they are developing the Omicron specific vaccine, but no Omicron specific booster vaccine studied shared to date. They are working on it. Hopefully we soon will get the vaccine also. Thank you very much. Anyone have a question? You can ask.
Hello, everyone. Thank you, Dr. Avinash. I have a question.
Yes, please ask.
If I took the first dose and the second dose of the vaccine from, for example, from Pfizer, so I can take the booster dose from another, like Moderna?
I understand. So you took the second dose of Pfizer, but now you want to take the booster of the Moderna or other biotech. Am I right?
Yes.
Yeah, okay. Yeah, so you can take, because my personal experience is that, and I also confirmed from one of my infectious disease specialists, like I got my vaccine that is Sinopharm, which was from the China, but I took the booster dose of the Pfizer. So yes, you can take of any, but you have to take it as soon as possible.
Yeah, okay, thank you.
Yes.
I want to add something for that. So yeah, it's always there are some evidence that it's called mix and match. So like if you take the primary vaccine, let's say for Pfizer, and you are planning to take booster for Moderna or J&J, so there are some little evidence that it works better for some group of population in regards to protecting and preventing COVID. And but most of the people they survey, it seems like people does not want to do that. I don't know why, but there are like multiple, if you search, there are multiple data published that mix and match works better than the single like one vaccines. And this is a very common questions which I faced every day as I'm doing that vaccine hesitancy project. This is a very common question for the people, I guess. But Tamadar, you are definitely can, welcome to do, like if you want to take something else and that works better. And in regards to Omicron, Avinash, that's a very good presentation. I think at this moment, we all need to know that. And I want to tell my personal experience. I recently, actually, me and my whole family got I'm sure this is Omicron. And so this virus is, this type is very, very contagious. That's all I can say. And I have a feeling that eventually probably everyone will get it. And, that's how we'll develop herd immunity probably. But this is a very milder version, I guess. And also we all were vaccinated. So I think our symptoms are very mild, but it was mild, but it's like took us literally like 3 weeks to fully recover. Another thing is it is mostly upper respiratory symptoms like runny nose, headache, fever and body ache. It does not go through the lungs like not like a productive cough, but most of the time it is dry cough. Some of the people from my community and a couple of my colleagues, they also mentioned that respiratory distress and mild hypoxia. But nobody so far I have heard that needed to go hospital for oxygen or ventilation who are vaccinated. So the main important message I want to convey here is vaccination is the key, and still we have to do all the precaution. But other thing I heard, that's I'm very scared that it's if you get once COVID, it does not necessarily mean that you might not get second time. So although probably we have antibody against it, but there is no guarantee that you might not get the second time. So we should be we should take all the precautions whatever we have available in our hand. Thanks.
Thank you.
Okay, thank you, Sumi, for sharing that with us. I hope that you and your family are better now. So Lina and Omri has a question. Please go ahead.
Hi, everyone. Actually, I don't have a question. I have a comment on what just Sumi said. I myself, I got COVID 3 times. I think the last one most probably is Omicron. And so I don't think that having COVID one time will protect you from having it another one. Although I had 3 doses of vaccine, I had Sinopharm, first and second, and booster dose. One additional thing that I have noticed recently, I'm currently in UAE. Most of the people here have the symptoms, yet they have a negative PCR. For some reason, the PCR is always negative. Like everyone is moving around with these symptoms, but a negative PCR. So I think that's also beside it being really contagious, it's really mischievous also that you don't have, the tests are not working with it probably. That's it. That's what I wanted to add.
Thank you, Lina. I really appreciate your comments, and thank you, Sarah. Yeah, we all recovered well, and I think it was for my daughter. She recovered very fast. As children's immunities are better than adults, I guess. and she was vaccinated too. But for us, like it took 3 weeks, as I said. But Lina, I mean, that is correct, whatever you have mentioned. For the PCR portion, that's also, I have seen, I'm facing a lot of people, they have all the symptoms and they're PCR negative. The thing is here, I think as Omicron is very, very contagious, so probably people already get it. The, you know, like when people have very mild symptom, not everybody goes and tested it. So probably this is second time they are getting, and they already have the antibody against Omicron that makes PCR negative. So probably not in the active action, you know. So that's another thing I want to mention. And you are absolutely right. For Delta, it was like most of the people are asymptomatic, but they are carrier. Here, people are symptomatic, but the PCR is negative. So, you know, this virus, like based on their variant, it is working like different way. There are a lot to learn, but, you know, we are learning every day new things. Thanks for sharing.
I want to add something. Maybe the PCR, when it is negative, because it is winter, maybe it is flu or something else. I don't know.
When they do PCR, basically for us, they do for flu as well. Like it's a, you know, it's a protocol. They do influenza A, influenza B, and SARS-CoV-2. So usually PCR means like all three they do, especially in this season. So for us, like, you know, flu, like influenza A and B was negative, but PCR was, I mean, SARS-CoV-2 was positive, and that also applies for the other people whoever I talk to. But they have all symptoms, like, you know, sore throat. Start with sore throat, mild cough, fatigue, headache, like that, but they are PCR negative. And I mean, it's like, it's about the whole family. So it's, I don't know like how, so we are talking about it and we are discussing. So, you know, like that's one thing that probably people get 2-3 times and they have antibody. That's probably makes PCR negative, but there are no like, you know, like explanation for it.
Thank you for
Thank you, Sarah. Thank you both, Sumi and Ina. Thanks also to Mother. Myself, I had it a week ago, and it's very mild. I didn't have any symptoms. I just did the test because it's required to get the test nowadays in the nursing homes. And I found myself positive, so I isolated myself. Thanks God, no one in the family got it. Maybe they had it, but no symptoms. We tested my daughter, she was negative. So as far as the negativity of the test, there could be different possibilities. We are doing research now, so we can talk about the basics of the research. So the test has maybe the results, they might have positive or negative according to their specificity. So that might play a role. Number two, the Omicron, I think they discovered it in like, let's say 2 months or 3 months. It's moving around. It's like a target that's moving. So the organism itself, the virus, it has a protein. Each protein can be changed when it moves from one person to another. So although it's spreading very fast, while this virus is spreading, it changed itself. So if it changed some of the proteins that are used in the test, that might also explain why it's negative, although the patients may have mild symptoms. So it can spread, it can cause the symptoms, but it may not be detected with the use of the current PCR, and because they target a specific protein. If these proteins change for some mutations, then definitely the test will be negative. Is what I think, but we can talk to infectious disease or lab people may explain better. Thank you.
I have a question, maybe for Dr. Avinash and eventually to Dr. Nadir. So
Sure.
my question is, do they do like a mutation, genetic mutation testing for every single sample of COVID-19 positive patient or SARS-CoV uh, virus 2 for every single patient that tested positive, or just they take like random sample from each like lab and do testing to check if it is still the same mutation of Omicron or the new mutations is going on? Thank you.
Honestly speaking, I don't have any idea about it, but they must have a criteria like at what time they will check the genetic. But let's see, maybe Dr. Nader have any information about it.
I agree with you, Avinash. I know they do the genetic testing, like here at Sparrow, for example, but how frequent is it for every positive, or they select it just randomly? I'm not sure. We have to talk to the lab people as well. Thanks. That's a good question.
Yes, it's a good question. Even I think about it when I got a positive. Yeah.
Thank you. Yeah. Thank you, Dr. Nadir. Thank you, Avinash.
Right, so thank you, Dr. Nader. Thank you, everyone, for your valuable inputs. And thanks, Avinash, for good presentations, highly informative. So just for the time constraints, I think we're ready to move on for the next part of the agenda. So if anybody would like to share about their projects updates. I would like to step in and start, maybe people get encouraged. So thank you, Dr. Nader, for sharing with us about the Alzheimer organization. Actually, Dr. Lubaba sent an email to double check if we can remodify our already submitted abstracts. And they said we need to just do the rewording and paraphrasing for our content, and we can submit that. So the teams, her team, the screening for dementia in primary care settings, and also the team led by Dr. Lina also will be about the music and aging, and my team, the vitamin D, the vitamin D and aging. We're working on our projects to be able to submit it at the Alzheimer organization, and I expect we'll be sending it for you to review within this weekend, inshallah.
Inshallah. Thank you so much. This is great. Thanks for sharing.
Oh, thank you, Dr. Nader. I appreciate it.
So if anyone else has any ideas and new ideas about doing research project, or we can work on some of the data that we have, or want to join other teams, let us know. Thank you so much. And I would like to also encourage the fellows who present now and who will watch this later. We sent feedback. If you can fill that feedback and send it on that would be very helpful. We want to evaluate what we are doing and improve if there is room for improvement here. So I really encourage you to talk to other fellows who did not complete their feedback, and that would be great. Thank you.
Okay, thank you, Dr. Nader. So I think that's it for today's agenda. Would like to share with us your plan for next week.
Here I put some for next week team. If anyone wants to add or remove or modify, so maybe the topic will be endocrinology in older adults. I put the names here, and the team can decide and the person or the fellows can decide which one will do what. So I put Malaz and Muhammad Ibrahim. And then if someone wants to add more about COVID and updates, and we can work on also other research projects or discussion according to if there is any available time. Anything else you want to add, let me know.
Yesterday, I heard about a new virus that is Neocov. The Chinese scientists found it in the South Africa in the animal beds, and they are concerning that it required only one mutation to become infected the human, and it become very deadly than the Omicron and Delta. So if we have a presentation on it, that would be appreciated.
Thank you, Dr. Avinash. Maybe you can get in contact with Muhammad Ibrahim and his team,
Sure.
Dr. Hassan, if available also to see. Thanks.
The next presentation for the green team.
Yeah, maybe Dr. Avinash can talk to one of the other members in that team, or if you have time, Avinash, maybe you can present if no one available to present the update. The team is just to organize ourselves and at the same time to give everyone a chance or opportunity to present and share and get the skills, get the knowledge, get the other fellows, and by this also you will learn, hopefully, for the future. So it's kind of an opportunity for teaching others. So thank you. Did you want to ask a question, Muhammad Ibrahim?
No, I just asked is the coming presentation for the green team, because I think the green team did the presentation a week ago, or the week before.
Okay, maybe it's my just organizational skill. I put them, I copy paste, so maybe I need to redo that. But in your WhatsApp group, can you decide if one team is ready to present, and if the team members can just go into the app and select what topic, what presentation, or you want to discuss? Again, the teams are just organizing stuff around. So it's my fault to put the green team in 2 weeks duration, but any suggestions?
So the endocrinology, there is a specific topic, or?
So for all these topics, there is a link in the app to PDF, to the PowerPoint slides from AGS. So they have already the topic ready.
Oh, okay, I remember that one. You are muted.
Dr. Nader, you are muted.
Sorry, sorry. For the presenter, let's say, for example, just the mother wants to present the endocrine. You go to that file and see the slides. You can do the bare minimum, just go over the slide and present it next week or whatever. Or you can look up what's updated information about the topic, and then you can add it, or you can just pick and choose, select whichever slides that you want to present, and then you add your own. You can make changes as you wish. It's just for your practice as far as presenting a topic. You can do it from scratch. You don't have to go by that slide. It's just to help you build on something that's already done. If you have time to do like the guys did today, that presentation, this great presentation. So you can just go ahead by, you can submit your own presentation, but the files are there. It's for you to either use it as a whole, you can just present, go over it. It's just touch on the main ideas on the topic. If you want to add updates, that's also helpful. If you want to do anything else, that's also a positive thing. Thank you.
Okay, thank you, Dr. Nader.
So maybe the team leaders, maybe if you have a chance, maybe you can talk together, see which team they want to present next week, and they can add it, and then I can try to make sure this not repeated, like the same team will be doing presentation back to back or something like that. Thank you.
Thanks, Dr. Nader, for your continuous support for us throughout the fellowship and throughout our career progression. We appreciate that. Thanks, Dr. Sulafa, Dr. Alaa, Dr. Avinash, for your great presentations today. And thank you, everyone, for your inputs and sharing your experiences. I hope everybody's healthy and everybody's safe. And with that, it's just a wrap up for today's meeting. Thank you all. Take care.
Dr. Nader, if you can have a minute after we finish, I want to speak with you something.
Sure.
Thank you.
Thank you, everyone, and have a wonderful day, night, and see you next week. And you are doing a good job, so keep it up.
Well,
Thanks. Have a wonderful day. Thank you. Assalamu alaikum.
Thank you.
Thank you.
Thank you, Dr. Nader, so much.
Thank you, everyone.
Thank you.
So, Dr. Nader, I have a friend, she is a dentist, and she finished all the American board exams related to the dentist, and she's interested in research, and she is doing a master in University of California online of orofacial pain and oral medicine. And she's particularly focusing in the sleep disorder, apnea, and psychological and behavior analysis in geriatric with the orofacial pain. And she's wondering if that she can join next year. I said I need to ask because I think most of us who are in medicine, even though we are not interested, some of them may not interested in matching, but interested in research and learning. So is this a possibility or?
Definitely. Actually, now in the coming, like in the future, we want to combine the fellowship is not going to be only for the medical. We want to also touch base with other, not only international, maybe we can get in touch with students from here, not only medical students, maybe nursing students, so that it will be like a team approach to a focus problem, and then they can take the project and then publish on that. So definitely, yeah.
I will give her your email, and
yeah, she can
tell her that it will be open on May, the applications, so she can apply. Okay, that's cool. And for my side, I got another interview, alhamdulillah, two of them. Yeah, at the end, they just discovered me at the end of the story.
That's good. That's good. That's good. That's great. Alhamdulillah. Good luck. Yeah.
Alhamdulillah. Inshallah, this year we're looking forward.
Excellent.
and thank you for your time. And that's it. Thank you very much.
You're welcome. No problem. Thank you. Thank you for everything. I wish you all the best. Thank you for sharing as well.
Thank you. Bye-bye. Have
Bye.
a nice day. Bye.
Thank you, everyone.
Thank you, Dr. Alaa. Thank you.
Thank you. Thank you so much.
Thank you, Tahani. Thank you, Azza and Osama. Azza, do you have a minute?
Yes.
So how's the fellowship? So you're gonna start June, July, or how?
I'm supposed to start in July.
Mm-hmm.
But they need me to come early so I can do like an orientation. Yeah,
orientation, yeah. Maybe 2 weeks early or something.
Yes, they want me to come as early. I will come in May.
In May. Oh, okay.
Yes.
That's good.
May, and so they're doing their paperwork and the application for the Pennsylvania license.
Mm-hmm.
They said I cannot start before I finish my license process.
Oh yeah, yeah. Hopefully it's not gonna take long. I think maybe a few weeks, maybe in a month or two you'll get it. Yeah.
Inshallah, inshallah.
Inshallah. Good luck. That's a good thing.
Thank you.
Thank you so much.
Thank you, Dr. Nader.
You're welcome. Thank you.
Thank you.
How are you, Dr. Osama? Are you there? Okay. Assalamu alaikum. Thank you.